1998, FDA approved PDE5 inhibitors for erectile dysfunction. From then, PDE5 inhibitors are the first line treatment for erectile dysfunction. Good afternoon. Today I am going to talk about the clinical importance of PDE5 inhibitors. Actually, PDE5 inhibitors synthesized for the purpose of angina pectoris, but its side effect was increased erection in male patients when it came to trial. So, from 1995, physicians started to use PDE5 inhibitors for erectile dysfunction. In 1998, FDA approved PDE5 inhibitors for erectile dysfunction. From then, PDE5 inhibitors are the first line treatment for erectile dysfunction because of their safety profile, rapid efficacy, and convenient oral administration. Before going to the mode of action of PDE5 inhibitors, I will explain the physiology of erection. When sexual stimulation occurs, nitric oxide is synthesized from pineal nerve endings and endothelial cells. This nitric oxide increases the cyclic GMP level in the arterial smooth muscle cells, and this cyclic GMP relaxes arterial smooth muscle cells, and copper cavernosum increased blood flow into the corpus cavernosum filled with the blood, and the erection occurs. But this cyclic GMP is not a stable one. It converted into GMP with the help of phosphodiesterase 5 enzyme. So, detumescence occurs when cyclic GMP degrades. When we administer PDE5 inhibitors, it act on it bound to phosphodiesterase 5 enzyme and blocks the cyclic GMP to degrade. So, this increase the cyclic GMP in the arterial smooth muscle cells causes the erection to maintain. Now, the clinical importance of PDE inhibitor. In psychogenic ED, nitric oxide will not be synthesized from the pineal nerve endings and endothelial cells. So, nitric oxide cyclic GMP pathway will be blocked. So, in psychogenic ED, PDE5 inhibitors won't work. The second clinical importance is whenever we administer long-acting PDE5 inhibitors, this detumescence pathway will be blocked. So, even in minimal sexual stimulation, nitric oxide will be released and only the erection pathway will be maintained, and with minimal sexual stimulation, patient feel erection. This minimal erection increases the arousal of the patient, and more and more nitric oxide will be synthesized, and erection patient feel good erection. The third thing, even in organic ED, patient sometimes won't feel erection with PDE5 inhibitors because of low dose of when we administer low dose of PDE5 inhibitors, this blockade will not be applied, so patient will not feel erection. Another thing, when PDE5 inhibitors to work, patient needs sexual stimulation. So, when patient is not having adequate sexual stimulation, in organic ED also patient won't feel erection. In sometimes food may interact with PDE5 inhibitors, and it may cause failure. Okay. Sildenafil citrate and varnafil citrate have short-acting PDE5 inhibitors with a mean half-life of 4 hours. and tadalafil have long-acting PDE5 inhibitor which have mean half-life of 18 hours. Actually, when short-acting PDE5 inhibitors won't work, we can combine long-acting PDE5 inhibitors, low dose of long-acting PDE5 inhibitors with short-acting PDE5 inhibitors when in need. On demand basis, we can administer short-acting PDE5 inhibitors. Sildenafil citrate and vardenafil should be administered 1 hour before sexual intercourse, and because its Tmax is 1 hour and vardenafil Tmax is 2 hours, so it should be administered 2 hours before intercourse. If it is on demand, we are giving tadalafil, we can give daily dose. Contraindication of PDE5 inhibitors: when patient is on nitrate therapy, we should not administer PDE5 inhibitors. When patient is having retinitis pigmentosa and non-arthritic anterior ischemic optic neuropathy, we should not administer. In severe hepatic impairment and severe renal impairment, we cannot administer PDE5 inhibitors. Benefits: when we administer long-acting PDE5 inhibitors with short-acting PDE5 inhibitor, patient is able to perform at any time. Convenient to carry and consume. Nowadays, this combined drug is available in the market. Cost effective. Thank you.